Hello, my name is Dr. Yvette Cologne. I am a longtime American Cancer Society volunteer and a longtime oncology social worker. I'm currently Associate Professor at the Eastern Michigan University School of Social Work, and it is my great pleasure to present the ACS Quality of Life Lecture 2017. My presentation is called I Haven't Got Room for the Pain, Time, Space, and Suffering in Cancer Pain. Together, we'll be exploring the damaging psychic effects of cancer pain and suffering. We'll challenge myths and misconceptions about pain to help oncology social workers support cancer pain patients in minimizing suffering and regaining control over their lives. Pain is not just the doctor's or the nurse's or the pharmacist's domain. In fact, oncology social workers can do so much to relieve suffering that it's unethical not to address it. Let's start with pain. We don't realize how much we're surrounded by pain. It's all around us. It's ubiquitous in any kind of medical and oncology practice. It's part of literary and cultural contributions. It is socially ever present. Pain has been with us for over 2 million years, since our modern human ancestors have existed. And we've been talking and writing about it since we have acquired language. Whenever I look for quotes about pain, I'm surprised at finding so many that cast pain as a noble, character-building gift or punishment. But what is pain? People have had plenty to say about it throughout history. The greatest evil is physical pain. This was said by St. Augustine, an early Christian theologian and philosopher whose writing influenced the development of Western Christianity and Western philosophy. The scourge of life and death's extreme disgrace, the smoke of hell, that monster called pain. Sir Philip Sidney, an English poet, courtier, scholar, and soldier who is best remembered as a prominent figure of the Elizabethan age. Pain is a more terrible lord of mankind than even death itself, said by Albert Schweitzer, a French-German theologian, philosopher, and physician. Pain is such an uncomfortable feeling that even a tiny amount of it is enough to ruin any enjoyment. Will Rogers, a vaudeville performer, American cowboy, humorist, newspaper columnist, and social commentator. Physical pain is not a simple affair of an impulse traveling at a fixed rate along a nerve. It is the resultant of a conflict between a stimulus and the whole individual, said by René Leriche, a surgeon, a French physiologist who was a specialist in pain and vascular surgery in the late 1800s throughout the early and mid 1900s. Of pain, you could wish only one thing, that it should stop. Nothing in the world was so bad as physical pain. In the face of pain, there are no heroes. George Orwell was an English novelist, essayist, journalist, and critic who was deeply aware of social injustice. With every physical pain, my moral fiber unravels a little. Mason Cooley was an American literary academic, an aphorist, who was Professor Emeritus of French, Speech, and World Literature at the College of Staten Island. Few things a doctor does are more important than relieving pain. Pain is soul-destroying. No patient should have to endure intense pain unnecessarily. The quality of mercy is essential to the practice of medicine. Here, of all places, it should not be strained. Marcia Angel, American physician, author, and the first woman to serve as editor-in-chief of the New England Journal of Medicine. I surmise that later generations will likely scoff at the means by which we are currently addressing pain. Melissa Cady, DO, is an osteopathic physician, certified in anesthesiology and pain medicine, an author, and a person with pain. And even in publishing and typesetting, lorem ipsum is filler text usually used to demonstrate the graphic elements of a document or visual presentation. Replacing meaningful content with placeholder text allows designers to design the form of the content before the content itself has been produced. But the standard lorem ipsum passage was adapted from oratory by a Roman philosopher and politician and lawyer, Cicero, who came from a wealthy municipal family and is considered one of Rome's greatest orators and prose stylists. I will not read the Latin for you, but know that this standard passage generally translates to, "There is no one who loves pain itself, who seeks after it and wants to have it simply because it is pain." This de lorem ipsum, pain in and of itself, has been used since the 1500s. And pain also reveals itself in poetry. In her stark consideration of pain, poet Emily Dickinson, who lived between 1830 and 1886, provides a very accurate representation of how pain can take over a life. Pain has an element of blank. It cannot recollect when it began, or if there were a time when it was not. It has no future but itself. Its infinite contain its past, enlightened to perceive new periods of pain. I think Dickinson is talking about two important aspects of pain, its dominance and its timelessness. The poem contains references to past, present, and future time. Pain can be so overwhelming that it erases any memory of having experienced anything but pain. The person with pain remembers the past as having consisted only of pain. In distress, persons with pain see only unremitting and unrelentless pain in their futures. Their lives and identities have become only pain. Cancer pain can be dark, stigmatizing, isolating, and distancing for patients and their loved ones. As Gunderman wrote in 2002, in the space of mere seconds, pain can so quickly invade and dominate the psychic landscape that no room is left to attend to anything else. The person with pain is forced into a strange and challenging journey. Being diagnosed with cancer can be a profound loss, or it can be seen as many losses of independence, dreams and aspirations, of goals. It can threaten one's very personhood, a loss of the person the patient used to be and can still be. And what is pain? In 1979, the International Association for the Study of Pain released their medical definition of pain, which we still use: an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. But this is the definition of pain that I want you to remember. It is whatever the experiencing person says it is, existing whenever the person says it does. This is a definition that was developed by pain management nurse Margot McCaffrey in 1968, 11 years before the IASP created their medical definition. This is the definition we care about. Dame Cicely Saunders coined the term total pain to characterize the multidimensional nature of the patient's pain experience, to include the physical, psychological, social, and spiritual domains. The concept of total pain in the assessment and management of cancer pain says that optimal pain relief is not possible if all dimensions of total pain are not addressed. And that means we must acknowledge the psychic devastation cancer pain can cause. We must also acknowledge that in some ways, pain remains a mystery. Why do human beings experience pain? We need some pain. It's a survival mechanism whose purpose is to protect the body, to warn of some important danger. It's a signal that the body has been harmed in some way. Running a marathon takes a toll on the body, but the resulting pain is perceived positively, not negatively. Sometimes pain doesn't doesn't cause actual tissue damage, but potential tissue damage, like riding on a roller coaster and experiencing the fear of what might happen if you fall. Pain protects and warns us that something is wrong or might go wrong. Without it, we'd be so injured and overwhelmed with physical trauma. But pain works in a very interesting way. Pain perception, which is called nociception, is the process by which a painful stimulus is relayed from the site of the noxious stimulus to the central nervous system. The brain receives information for further processing and action. How pain treatment works. All interventions are designed to interfere with, diminish, or prevent pain signals from reaching the brain. We also deal with different types of pain, and it's important to know the difference. Acute pain is time limited, generally less than 6 months. It's usually associated with physical trauma or injury with a predictable healing process. Chronic pain, however, persists longer than 6 months. It has a limited physical pathology, and it persists beyond the anticipated healing process. A headache can be acute, for example, a sinus headache, or chronic, for example, a migraine headache, or related to cancer, a brain tumor, for example. Breakthrough pain. Breakthrough pain is sudden, short-lived episodes of moderate to severe pain that emerge spontaneously or in response to a specific activity or movement, despite otherwise stable or adequately controlled baseline or background pain. It is sometimes called episodic pain or incident pain, and it is common in certain diseases like cancer. Long-lasting pain caused by disease and/or short-term pain caused by diagnostic procedures or treatment can be the result of a cancer diagnosis. Surgery, chemotherapy, and radiation may produce painful conditions that persist long after the treatment has ended. But because it can be both acute and/or chronic pain in unpredictable ways, cancer pain differs from many other types of pain. Cancer is an awful disease, and so is pain, and they exist in very complicated contexts. Cancer can cause pain by growing into the tumor site or growing into or destroying nearby tissue. Cancer pain can come from the primary cancer itself or from other areas of the body where the cancer has spread. As the tumor grows, it may put pressure on nerves, bones, or organs, which cause pain. Sometimes the pain is due to cancer treatment, chemo-induced peripheral neuropathy, for example. Cancer pain and any complications involved in managing it can create significant distress. It affects activity, sleep, energy, intimacy, and more. We also need to understand the psychological experience of cancer pain. Because cancer pain is usually treated medically, patients and healthcare providers can underestimate its impact on psychological distress. It affects self-efficacy, self-esteem, independence, mood, for example, anxiety, depression, anger, and fear. It affects control, trust in one's own body. An individual's beliefs about pain and its treatment contribute to perception, expression, and response. How I experience pain is influenced with how I perceive it. In this cartoon, a woman is looking through a magnifying glass and realizing that her pain is great. But at the bottom, when she looks at the same area of pain under a microscope, it seems diminished, and she thanks the doctor and says, "This feels so much better." How she perceives her pain is influenced by beliefs, mood, and prior experiences. Our 16th to 21st century understandings of pain lead us to believe that pain is no longer a one-way process. An injury or the site of damage sends signals to the brain. But we now know that pain is a very interactive process. The pain is not felt until the signals are registered through the central nervous system into the brain. It's a very, very interactional process that is affected, again, by mood, by beliefs, by perceptions. How one perceives pain is influenced by how they perceive it. Beliefs, again, mood, and prior experiences. How one expresses themselves in response to pain is also influenced by beliefs, moods, and prior experiences. Both of these are common expressions of pain. In the first, the expression is one of screaming and feeling frantic. In the second, the expression is one of stoicism and quiet despair. These patients may be experiencing the same level of severe pain, but expressing it very differently. This is our bread and butter. As oncology social workers, we help people with their experience of cancer. Pain is no different. We have a social understanding of cancer pain. Cancer and pain, separately and together, confer stigmatized identities. They profoundly affect roles and identities, relationships, intimacy, social status, employment, and work identity. We know that there is an existential or spiritual understanding of cancer pain. A relationship with a higher power or a deep philosophy of life can be affected by cancer pain. It can create existential crisis, a moment in which an individual questions the very foundations of their life and whether their life has any purpose, meaning, or value. Feelings of despair or hopelessness can exacerbate existential anxiety or dread, heightening distress. And we have a comprehensive biopsychosocial understanding of cancer pain. Pain is best understood in terms of a combination of biological, psychological, social, and existential or spiritual factors rather than purely biological terms. Cancer pain is a complex, multidimensional, and subjective experience unique to every individual. Pain is not just a symptom, nor is it meant to build character. Pain is not a result of past mistakes or a punishment for wrongdoing. It affects all aspects of a person's life, including those around them. According to the American Cancer Society, in 2017, an estimated 1.7 million Americans will be diagnosed with cancer, and approximately 600,000 U.S. cancer patients will die. The cancer death rate in the U.S. is down 25% in the past 26 years. Treatments have become more sophisticated. Pain specialists believe that about 90% of cancer pain can be managed adequately. Managed, not eliminated. Let's help our patients manage their expectations about the reduction and management of pain. In 1986, the World Health Organization published their first guidelines for controlling cancer pain, 31 years ago. Some of you weren't even born yet. Since then, there have been more updates as well as guidelines and recommendations from other organizations. But 90% of cancer pain is not managed adequately today. What's happened? Today, more than half of all cancer patients experience severe pain and do not have their pain adequately managed due to inappropriate and inadequate pain care. Over 70% of hospitalized patients suffer with severe pain. Up to 33% of all cancer patients continue to have pain after curative therapies. According to the Institute of Medicine, now the National Academies of Science, Medicine, and Engineering, the magnitude of pain suffered by individuals and the associated costs constitute a crisis for America, both human and economic. There are many articles and resources that address interventions for and relief of cancer pain. Few address alterations in patients' psychic time and space and the effects of pain that can be so debilitating that an individual's very personhood can be extinguished. But why do people have to suffer from cancer pain? Isn't cancer itself enough? Unrelieved pain has complicated physiological consequences that affect the patient's emotional and cognitive experiences. Patients with pain can experience weakened concentration, impaired attention, and depressed mood states. A negative physiological status negatively affects and influences psychological well-being. Pain greatly detracts from many aspects of a patient's quality of life. When pain is seen as psychologically and physically threatening, the patient may develop pain-related fear, which can be more disabling than the pain itself. In addition to all of the time and attention necessary to treat and cope with cancer, it takes time to have cancer pain. It takes time to try to find appropriate providers and to be believed. It takes time to find a prescriber that will write for needed medication, a pharmacy that stocks it, and the right person at the insurance company that will approve payment. It takes time to fight the insurance company for the coverage a patient is entitled to. It takes time to be treated for pain. It takes time to find the strength to talk with a social worker or support group or family or friend. It takes time to complain of pain for the 10th or the 100th or the 1,000th time. But let me back up a little bit. People do not complain of pain. They report pain in different ways. We are the ones who can help them find the words, the language to report their pain and what pain does to them and their families. The experience of pain invades and dominates the physical and psychosocial domains of a patient's existence, as Gunderman so eloquently put it. It has a very real context in the form of a cancer disease process, but we know that the subjective responses to pain sensations are psychosocial processes that influence the experience of cancer and the capacity to cope with it. Anticipation of pain is an important fear associated with cancer, and uncontrolled pain strips away morale and motivation and quality of life. The specter of pain is always present. Interacting biopsychosocial spiritual dimensions are important areas of focus in a comprehensive, skillful approach to assessment and treatment of cancer pain. But there is a hierarchy of what we might term legitimate pain. Acute pain is generally seen as legitimate. Chronic pain conditions that are poorly understood, like fibromyalgia, are not considered legitimate. Because cancer is so prevalent and generally understood, associated pain may be considered more legitimate than other conditions. But even seeking help for the management of cancer pain can be difficult. The complex social context of cancer pain in this country means that care is worse for people of color, for the poor and uninsured or underinsured, for elders, for children, for women, for institutionalized individuals, anyone who is in a nursing home or a prison. Pain care is worse for people who speak English as a second language, people who are cognitively impaired, people with persistent mental illness. This is a group that's not even on the radar screen for pain management interventions. And people who were or are substance abusers who are often singled out for bias. Do we as oncology social workers ever see individuals such as these in our practice? Of course, they are our practice. While the science of pain continues to evolve and new therapies are becoming available, many people with moderate to severe pain suffer higher rates of depression, anxiety, job loss, financial distress, decreased physical activity, isolation, suicidal thinking, and a host of other psychosocial problems. Despite growth in pain knowledge, medications, and integrative therapies, pain remains highly stigmatized. Stigma is classically defined as an attribute that is deeply discrediting. It is a broad social issue, even in healthcare. We stigmatize what we don't understand, what we can't fix easily, we can't see, and we don't know how to help, So we might think, it's your problem, not mine. It's your fault, not mine. Stigma can profoundly affect the experiences of those who suffer from particular medical illnesses. It can lead to delayed diagnosis, poor adherence to treatment, and physical and emotional stress. The individual, professional, and societal responses to pain as a significant health problem is cloaked in stigma. Pain often is accompanied by threats to autonomy and competence, positive identity, and meaningful social relationships. Providers in all disciplines are challenged to recognize that social values and professional attitudes can create and reinforce isolation and stigma of pain sufferers. As a result of myths, misconceptions, and preconceived judgments, patients' social support networks may diminish at a critical time of need. Cancer patients may experience estrangement and feeling physically or psychologically flawed as a result of having pain. Pejorative labeling, for example, cancer pain patients are drug-seeking, malingering, or faking, or that pain is all in a patient's head, by healthcare providers and others can cause people with pain to feel stigmatized, which can lead to strained interactions, embarrassment, and feelings of estrangement. And there simply aren't enough providers who can appropriately assess and treat pain, including cancer pain. In 2010, for example, there were an estimated little over 9,000 pain programs and sole practitioners, clinics, anesthesiologists, other physicians, chiropractors, treating an estimated 17 million Americans suffering from chronic pain, including cancer. The rest, it can be surmised, were being treated by non-pain specialists in a variety of settings other than pain clinics or programs. Not all provide multidisciplinary pain care. Much of pain treatment today focuses on a single treatment modality. The location of pain management practices primarily corresponds with larger population centers. The number of pain specialists practicing in the United States, especially in rural communities, is sadly inadequate, despite increasing evidence that untreated and undertreated chronic pain is the nation's leading public health problem. Although not all cancer pain patients need constant specialized outpatient care, many more than are currently being treated could benefit from appropriate assessments and more effective pain management treatment plans. We have to acknowledge the very real problems of abuse, misuse, and diversion of prescription pain medications, and this affects access for cancer patients. Pain and addiction can be challenging co-occurring disorders, but the majority of people, when prescribed opioid medications for pain, use them correctly without developing addiction. We must be vigilant, though, because opioids are strong medications and patients must be supported to use them appropriately. Those in the community of cancer pain and those in the community of substance abusers have very real needs that must be addressed, but they are not the same community, and the strategies used to curb misuse, abuse, and diversion cannot be applied to people with cancer pain. It is not a good strategy, for example, to remove approval for specific opioid medications to reduce abuse, because this will disadvantage people who benefit from opioids and use them appropriately. It is not appropriate to treat cancer patients taking prescribed opioids as though they are quote-unquote drug addicts. Society cannot ignore, stigmatize, or punish either community. There are some very real fundamental things that oncology and other social workers can do. We must stop calling opioids narcotics. The word narcotic often is used broadly, inaccurately, or pejoratively outside medical context. It belongs in legal, not healthcare settings. Let's please call them opioids and not narcotics. Prescription opioids are FDA-approved medications prescribed for pain management. Narcotics are dealt on the street. They are confiscated by law enforcement. Using street terms to describe prescription medications is confusing to patients and families and reinforces stigma and bias. We must stop conflating pain with addiction and abuse. Let's stop stigmatizing people with pain and people with addiction disorders. know that tolerance, dependence, and addiction are not the same thing. They are terms with specific definitions and cannot be used interchangeably. When we define key terms in pain management, we know that these terms have very specific definitions. Tolerance is the need for an increased dosage of a drug to produce the same level of analgesia, of pain relief, that previously existed. Tolerance also occurs when a reduced effect is observed with a constant dose. Pseudotolerance is the need to increase dosage that is not due to tolerance, but due to other factors, such as disease progression, a new disease, lack of adherence, increased physical activity, change in medication, drug interaction, addiction, or problematic behavior. Physical dependence can be described as the occurrence of withdrawal symptoms after opioid use is stopped or quickly decreased without titration. This is not addiction. Pseudo-addiction can be called drug-seeking behavior that seems similar to addiction, but is underneath due to unrelieved pain. This behavior stops once that pain is relieved. We might think of it more accurately as relief-seeking rather than drug-seeking. And addiction is the psychological dependence on the use of substances for their psychic effects and is characterized by compulsive use despite harm. Addiction should be considered if patients no longer have control over medication use and continue to use the drugs despite harm. It is inhumane to deny people with cancer pain appropriate treatments or tell them to just deal with it. You wouldn't do this, but you'll work with patients who have heard this from others. Untreated or undertreated pain is more than just an annoyance, more than just discomfort. There are profound effects in someone who lives with pain. It can be so debilitating that an individual's very personhood can be affected. And look, you're here watching this because you know that this is important. Now that I've brought you down, I hope that you can do something. People hurt. People suffer. Levels of pain can change, but everybody suffers. And it is so, so difficult to acknowledge suffering. Henry Nouwen said, "Let us not underestimate how hard it is to be compassionate. Compassion is hard because it requires the inner disposition to go with others to places where they are weak, vulnerable, lonely, and broken. But this is not our spontaneous response to suffering. What we desire most is to do away with suffering by fleeing from it or finding a quick cure from it. When we can't fix something, it's easy to overlook or not acknowledge the problem. Suffering is not easy to understand, and certainly not easy to treat medically. We know how to develop trusting relationships with strong working alliances with our patients. Humanistic, mutually respectful relationships support resilience by fostering positive connections. Recognizing and acknowledging someone's suffering can be an amazing start to that relationship. Eric Castle said that patients suffer from disease and treatment. If the relationship between pain and suffering were better understood, our treatments would be more effective. At the conclusion of the 13th World Congress on Pain in Montreal, Quebec, Canada, in 2010, the International Association for the Study of Pain hosted an International Pain Summit to address the tragedy, yes, tragedy, of unrelieved pain in the world. At the conclusion of the summit, the delegates adopted a declaration that access to pain management is a fundamental human right. The Declaration of Montreal recognizes the intrinsic dignity of all persons and states that withholding of pain treatment is profoundly wrong, leading to unnecessary suffering, which is harmful. It declared that the following human rights must be recognized throughout the world. The right of all people to have access to pain management without discrimination. The right of people in pain to receive acknowledgement of their pain and to be informed about how it can be assessed and managed. The right of all people with pain to have access to appropriate assessment and treatment of the pain adequately by trained healthcare professionals. The Declaration addresses the obligations of governments and healthcare institutions and all healthcare professionals to provide access and appropriate treatment to people with pain. So what can you do in your daily practice? Open your heart to pain and suffering. Incorporate our ethical mandate always to do something to improve our patients' and families' quality of life. Provide validation and let someone know that you believe their reports of pain. This can be a lifeline. It's everyone's responsibility to acknowledge, address, and provide support for cancer patients experiencing pain. Otherwise, they'll continue to have pain and continue to suffer, and you will suffer too. We have information about effective interventions for cancer pain: medications, physical medicine and rehab, surgical procedures, mind-body approaches, and a wide variety of integrative interventions. Some of you may even provide those interventions: cognitive behavioral therapy, guided imagery, relaxation, breathing techniques, biofeedback, hypnotherapy, and more. Interventions are not just about the location and intensity of someone's pain, it is also about the consequences of their pain. Interdisciplinary, integrative approaches are critical. Creativity and commitment are necessary. Relentless optimism is required. Expecting oncology social workers to address cancer pain is not such an unrealistic expectation. After all, the principles and values in cancer pain management have much in common with those of social work. In both, comprehensive quality assessment and treatment are individualized, patient and family-centered, and multidimensional. I want to share two stories with you. The first is Patty, who was 19 when she had to leave college and return to live with her parents after she was diagnosed with osteosarcoma and had part of her leg amputated. Michigan is a beautiful state with lots of Great Lakes coastline around the Lower Peninsula and beautiful inland lakes. Patty's parents lived on such a lake. But if you know basements in Michigan, you also know that sometimes they could be a little damp. Everybody has a sump pump to draw the water away. In the course of a conversation about her continuing pain, I asked Patty where she felt safest and most comfortable. She said her parents' basement. I was immediately distressed. I had assumed she would automatically talk about the beach because that was my perfect image. When I asked her more about it, she said that there was a small laundry room in the basement of her parents' home. When she had pain, she would go downstairs, dry some clothes in the dryer, and lie down in front of it. The rhythmic cycle of the drum soothed her, and the warmth felt so good. When the clothes were dry, she'd put them on top of her for a bit. This is what helped her get through the worst parts of her day. You can teach someone like Patty or her parents to heat clothes or blankets because it feels good. You can provide distraction and help patients learn those techniques themselves. You can talk about simple things that people can do for themselves. I also think of Paul often. When I was a young social worker and didn't know anything about pain, I started working with Paul. Paul had polio as a child and had an atrophied arm, and he compensated well for not having the use of one arm. He drifted in life for a while, then went back to school and finished his education. He went to law school later in life. He learned Spanish so he could provide good services to immigrants. He had a child later in life, after he got married, also later in life. Then he was diagnosed with a terrible cancer. He had a lot of pain. He was uncomfortable sitting in his chair, and he often paced. And he often felt bad about asking me if he could pace. Very often, even though we were talking about his cancer diagnosis, he would drift off and talk about hiking and camping and the Appalachian Mountain Club and how excited he was to introduce this not only to his wife but also his young child. I really thought I wasn't doing a good job letting him talk about things that weren't about his cancer, about coping with his experience, about trying to cope with his pain. Until finally I realized that this was his way of coping, of distracting himself from the pain, of talking about something that brought him such immense joy, and immense joy at sharing it with the family that he loves so much. And I learned a lot from Paul, who taught me so much. The need for public outcry for the millions of Americans struggling with cancer pain is greater today than ever before in light of the many assaults to the right to appropriate and dignified care. Barriers and disparities continue to impede access to appropriate and reasonable medical care for people struggling with cancer pain and deter even the most compassionate care providers. It's critical that each of you raise your voices singularly and together to demand the care that people with pain, cancer pain, and other types of pain deserve. It's only by continuing to demand attention to the ever-worsening barriers and unacceptable suffering that change will occur. It takes just a little effort to become knowledgeable about cancer pain and suffering. It takes little effort to support the right to appropriate pain management. It takes little effort to support our healthcare colleagues who provide good pain management, to support pain advocacy organizations, to write to online and print news outlets and contact our elected representatives. They do pay attention. It takes little effort to challenge bad laws, policies, and practices that put cancer pain care in jeopardy. And it takes just a little effort to challenge stereotypes, sloppy thinking, and lack of accountability. As non-medical professionals, meaning not the doctor, nurse, or pharmacist, half of what you can do is to change your language and help patients change theirs. Don't use street language, and provide patients and families with clear and supportive education and information. Everyone deserves a chance to heal and grow. We can help change the narrative of cancer pain and suffering to one of hope and help and dignity. We can fill time with hope, space with beauty, and we can change suffering to healing. Thank you so much for your interest in supporting patients with cancer pain, and thank you so much for your interest in the American Cancer Society 2017 Quality of Life Lecture.